Losartan potassium tablet type E. Zaart. Composition. Zaart 25. Each film coated tablet contains losartan potassium IP 25 mg. Colors. Titanium dioxide. Brilliant blue FCF. Zaart 50. Each film coated tablet contains losartan potassium IP 50 mg. Colors. Titanium dioxide and red oxide of iron. Dosage form. Tablet. Pharmacology. Pharmacodynamics. Pharmacotherapeutic group. Angiotensin 2. Angiotensins plan ATC code C09CA01. Losartan is a synthetic oral angiotensin 2 receptor antagonist. Angiotensin 2 a potent vasoconstrictor is the primary active hormone of the renin-angiotensin system and an important determinant of the pathophysiology of hypertension. Angiotensin 2 binds to the AT receptor found in many tissues. Example: vascular smooth muscle, adrenal gland, kidneys, and the heart, and elicits several important biological actions, including vasoconstriction and the release of aldosterone. Angiotensin 2 also stimulates smooth muscle cell proliferation. Losartan selectivity blocks the AT receptor in vitro and in vivo. Losartan and its pharmacologically active carboxylic acid metabolite E/3174 block all physiology relevant action of angiotensin 2, regardless of the source or route of its synthetics. Losartan does not have an agonist effect or not dose. It blocks other hormone receptors or ion channels important in cardiovascular regulation. Furthermore, losartan does not inhibit ACE, the enzyme that regards bradykinin. Consequently, there is no potential of undesirable bradykinin medication effect. During administration of losartan, removal of the angiotensin 2 negative feedback on renin secretion leads to increased plasma renin activity. Increase in the PRA leads to an increase in angiotensin 2 in plasma. Despite this increase in antihypertensive activity and suppression of plasma, aldosterone concentration are maintained, indication effective angiotensin 2 receptor blockage after discontinuation of losartan. PRN and angiotensin 2 value fell within 3 days to the baseline values. Both losartan and its principal active metabolite have a far greater affinity for the AT receptor than for the AT receptor. The active metabolite is 10 to 40 times more active than losartan on a weight-for-weight basis. Hypertension studies. In controlled clinical studies, once daily administration of losartan to patients with mild to moderate essential hypertension produced statistically significant reduction in systolic and diastolic blood pressure. Measurement of blood pressure 24 hours post dose relative to 5 to 6 hours post dose demonstrated blood pressure reduction over 24 hours. The natural diurnal rhythm was retained. Blood pressure reduction at the end of the dosing interval was 70 to 80% of the effect seen 5 to 6 hours post dose. Discontinuation of losartan in hypertensive patient did not result in an abrupt rise in blood pressure. Despite the marked decrease in blood pressure, losartan had no clinically significant effect on heart rate. Losartan is equally effective in males and females and in younger and older hypertensive patients. Pharmacokinetics. Absorption. Following oral administration, losartan is well absorbed and undergoes first-pass metabolism, forming an active carboxylic acid metabolite and other inactive metabolites. The synthetic bioavailability of losartan tablet in approximately 33% mean peak concentration of losartan and its active metabolite are reached in 1 hour and 3 to 4 hours respectively. Distribution. Both losartan and its active metabolites are increased 99% of same bound to plasma proteins. Primary albumin. The volume of distribution of losartan is 24 liters. Biotransformation. About 14% of an intravenously or orally administered dose of losartan is converted to its active metabolite. Following oral and intravenous administration of 14 carbon-labeled losartan, potassium circulating plasma radioactivity primarily is attributed to losartan and its active metabolite. Minimal condensation of losartan to its active metabolite was seen in about 1% of individuals studies. In addition to the activity metabolite, inactivate metabolite are formed. Elimination. Plasma clearance of losartan and its active metabolite is about 600 milliliter slash minimum and 50 milliliter slash minimum respectively. Renal clearance of losartan and its active metabolite is about 74 milliliter slash minute and 26 milliliter slash minute respectively. When losartan is administered orally, about 4% of the dose is extracted unchanged in the urine and about 6% of the dose is extracted in the urine as active metabolite. The pharmacokinetics of losartan and its active metabolite are linear with oral losartan potassium dose up to 200 mg. Following oral administration, plasma concentration of losartan and its activity metabolite decline proximity with the terminal half-life of about 2 hours and 6 to 9 hours, respectively. During once daily dosing with 100 mg, neither losartan nor its activity metabolite accumulates significantly in plasma. Both biliary and urinary excretion contribute to the elimination of losartan and its metabolites. Following an oral dose, intravenous administration of 14 carbon-labeled losartan in man, about 35% slash 43% of radioactivity is recovered in the urine and 58% slash 50% in the feces. Characteristics in patient. In elderly hypertensive patient, the plasma concentration of losartan and its activity metabolite do not differ essentially from those found in young hypertensive patient. In female hypertensive patient, the plasma levels of losartan were up to twice as high as in male hypertensive patient, while the plasma level of the activity metabolite did not differ between man and woman. In patient with mild to moderate alcohol-induced hepatic cirrhosis, the plasma level of losartan and its activity metabolite after oral administration were respectively 5 and 1.7 times higher than in young male volunteers. Plasma concentration of losartan are not altered in patient with the creatinine clearance about 10 ml/minute. Compared to patient with normal renal function, the AUC for losartan is about 2 times higher in hemodialysis patient. The plasma concentration of the active metabolite are not altered in patient with renal impairment or in hemodialysis patient. Neither losartan nor the activity metabolite can be removed by hemodialysis. Pharmacokinetics in pediatric patients. The pharmacokinetics of losartan have been investigated in 50 hypertensive pediatric patients, increased 1 month to decrease 16 years of age following once daily oral administration of approximately 0.54 to 0.77 milligrams/kilogram of losartan. The results showed that the activity metabolite is formed from losartan in all age groups. The results showed roughly similar pharmacokinetics parameters of losartan following oral administration in infant and toddlers, preschool children, school-age children, and adolescents. The pharmacokinetic parameters for the metabolite differed to the greater extent between the age groups. When comparing preschool children with adolescents, these differences became statistically significant. Exposure in infant toddlers was comparatively high. Indications: treatment of essential hypertension in adult and in children and adolescents 6 to 18 years of age. Treatment of renal disease in adult patients with hypertension and type 2 diabetics mellitus with proteinuria increased so same 0.5 gram as daily. As part of an antihypertensive treatment, treatment of chronic heart failure in adult patients when treatment with angiotensin converting enzyme inhibitors is not considered suitable due to incompatibility, especially of or contraindication patients with heart failure who have been established with an ACE inhibitor should not be switched to losartan. The patient should have left ventricular ejection fraction decrease of same some equal 14% and should be clinically stable and on a established treatment regimen for chronic heart failure. Reduction in the risk of stroke in adult hypertensive patient with left ventricular hypertrophy documented by ECG. Dosage and method of administration. Posology. Hypertension. The usual starting and maintenance dose in 50 mg once daily for most patients. The maximal antihypertensive effect is attained 3 to 6 weeks after initiation of therapy. Some patients may receive an additional benefit by increasing the dose to 100 mg once daily. Losartan may be administered with other antihypertensive agent, especially with diabetes. Hypertensive type 2 diabetic patient with proteinuria increase or equal 0.5 gram daily. The usual starting dose is 50 mg once daily. The dose may be increased to 100 mg once daily based on blood pressure response from the 1 month onward after initiation of therapy. Losartan may be administered with other antihypertensive agents. Example: diuretics, calcium channel blockers, alpha or beta blockers, and centrally active agents, as well as with insulin and other commonly used hypoglycemic agents. Example: sulfonylurea, glitazones, and glucosidase inhibitors. Next, heart failure. The usual initial dose of losartan in patients with heart failure is 12.5 mg once daily. The dose should generally be titrated at weekend intervals as tolerated by the patient. Reduction in the risk of stroke in hypertensive patients with left ventricular hypertrophy documented by ECG. The usual starting dose is 50 mg of losartan once daily. A low dose of hydrochlorothiazide should be added, and the dose of losartan should be increased to 100 mg once daily based on blood pressure response. Special population. Used in patients with intravascular volume depletion. For patients with intravascular volume depletion, a starting dose of 25 mg once daily should be considered. Used in patients with renal impairment and hemodialysis patient. No. Initial dosage adjustment is necessary in patient with renal impairment and in hemodialysis patient. Use in patient with hepatitis impairment. A lower dose should be considered for patients with a history of hepatitis impairment. There is no therapeutic experience in patients with severe hepatitis impairment. Therefore, losartan is contraindicated in patients with severe hepatitis impairment. Pediatric population 6 months to less than 6 years. The safety and efficacy of children aged 6 months to less than 6 years has not been stabilized. Currently available data are described in pharmacodynamics and pharmacokinetics, but no recommendation on posology can be made. 6 years to 18 years. For patients who can swallow tablet, the recommended dose is 25 mg once daily in patient increase 20 to decrease 50 kg. Dosage should be adjusted according to blood pressure response. In patient increase 50 kg, the usual dose is 50 mg once daily. In exceptional cases, the dose can be adjusted to a maximum of 100 mg once daily. Doses about 1.4 mg kilogram daily have not been studies in pediatric patients. Losartan is not recommended for use in children under 6 years old as limited data are available in this patient group. It is not recommended in children with glomerular filtration rate increased 30 milliliter slash minute slash 1.73 millimeter to meter. As no data, it is not recommended in children with patient. Losartan is also not recommended in children with hepatitis impairment used in elderly. All throughout consideration should be given to initiating therapy with 25 mg in patients over 75 years of age. Dosage adjustment is not usually necessary for the elderly. Method of administration. Losartan tablet should be swallowed with a glass of water. Losartan tablet may administer with or without food. Contraindications. Hypertensive to the active substance or to any of the excipient list in warning and precautions. Second and third trimester of pregnancy. So, hepatic impairment. Losartan should not be administered with aliskiren in patients with diabetes mellitus or renal impairment. Warning and precaution. Hypersensitivity. Angioedema. Patient with a history of angioedema should be closely monitored. Hypertension and electrolyte fluid imbalance. Symptomatic hypertension experienced after the first dose and after increasing of the dose may occur in patients who are volume and or sodium depleted by vigorous diuretic therapy, dietary salt restriction, diarrhea, or vomiting. These conditions should be corrected. Period of administration of losartan or lower starting dose should be used. This also applies by to children 6 to 18 years of age. Electrolyte imbalance. Electrolyte imbalance are common in patients with renal impairment with or without diabetes and should be addressed. In a clinical study conducted in type 2 diabetic patients with nephropathy, the incidence of hyperkalemia was higher in the group treated with losartan as compared to the placebo group. Therefore, the plasma concentration of potassium as well as creatinine clearance value should be closely monitored. SPLC patients with heart failure and a creatinine clearance between 30 to 50 milliliters slash minimum should be closely monitored. The concomitant use of potassium sparing diuretics, potassium supplements, and potassium containing salt substitute with losartan is not recommended hepatitis impairment. Based on pharmacokinetics data which demonstrate significantly increased plasma concentration of losartan periodic patient, a lower dose should be considered for patients with a history of hepatitis impairment. There is no therapeutic exercise with losartan in patients with severe hepatitis impairment. Therefore, losartan must not be administered in patients with severe hepatitis impairment. Losartan is not recommended in children with hepatitis impairment. Renal impairment. As a consequence of inhibiting the renin-angiotensin system, changes in renal functions, including renal failure, have been reported uh, as with other medicinal products that affect the uh, renin-angiotensin aldosterone system. Increase in blood urea and serum creatinine have also been reported in patients with bilirubin renal artery stenosis of the artery to the solitary kidney. These changes in renal function may be reversible upon discontinuation of therapy. Losartan should be used with caution. The patient with biliary renal artery stenosis or stenosis on the artery to a solitary kidney. Using pediatric patient with renal impairment. Losartan is not recommended in children with glomerular filtration rate decrease 30 milliliter minimum slash 1.73 meter as no data are available. Renal function should be regularly monitored during treatment with losartan as it may renal function should be regularly monitored during treatment with losartan as it may deteriorate. The applies particularly when losartan is given in the presence of other conditions likely to impair renal function. Concomitant use of losartan and ACE inhibitors has shown to impair renal function. Therefore, concomitant use is not recommended. Renal transplantation. There is no experience in patients with recent kidney transplantation. Primary hypochlorotonium. Patients with primary aldosteronism generally will not respond to antihypertensive medicinal product acting throughout inhibition of the renin-angiotensin system. Therefore, the use of losartan is not recommended. Coronary heart disease and cerebrovascular disease. As with any antihypertensive agent, excessive blood pressure decrease in patients with ischemic cardiovascular and cerebrovascular disease could result in myocardial infarction or stroke. Heart failure. In patients with heart failure with or without renal impairment, there is, as with other medicinal product acting on the renin-angiotensin system, a risk of severe arterial hypertension and renal impairment. There is no sufficient therapeutic experience with losartan in patients with heart failure and concomitant severe renal impairment in patients with severe heart failure, as well as in patients with heart failure and symptomatic life-threatening cardiac antihistamines. Therefore, losartan should be used with caution in the patient groups. The combination of losartan with the beta blockers should be used with caution. Aortic and mitral valve stenosis, obstructive hypertrophic cardiomyopathy. As with other vasodilators, special caution in indicated in patients suffering from aortic or mitral stenosis of or obstructive hypertrophic cardiomyopathy. Pregnancy. Losartan should not be initial during pregnancy unless continued losartan therapy is considered essential. Patient planning pregnancy should be changed alternative antihypertensive treatment with have a stabilized safety profile for use in pregnancy. When pregnancy is diagnosed, treatment with losartan should be stopped immediately, and if appropriate, alternative therapy should be started. Other warning and precaution, as observed for angiotensin converting enzyme inhibitor losartan and other angiotensin antagonist are apparently less effective in lowering blood pressure in black people than in non-blacks, possibly because of higher prevalence of lowering states in the black hypertensive population. Pregnancy and lactation. Pregnancy. The use of losartan is not recommended during the first trimester of pregnancy. The use of losartan is contraindicated during the second and third trimester of pregnancy. Epidemiological evidence regarding the risk of tetragenicity following exposure to ACE inhibitors during the first trimester of pregnancy has not been conclusive. However, a small increase in risk cannot be excluded. Whilst there is no controlled epidemiological data, is the risk of with the angiotensin 2 receptor inhibitors. Similar risk may exist for this class of medicinal products unless continued a 1-on-RA therapy is considered essential. Patient planning pregnancy should be changed to alternative antihypertensive treatment which have an established safety profile for use in pregnancy. When pregnancy is diagnosed, treatment with losartan should be stopped immediately, and it appropriate alternative therapy should be started. Exposure to A1 RA therapy during the second and third trimester is known to induce human fertility. Should exposure to losartan have occurred from the second trimester of pregnancy, ultrasound check of renal function and sequel of recommended. Infant whose mothers have taken losartan should be closely observed for hypertension. Lactation. Because no information is available regarding the use of losartan during breastfeeding, losartan is not recommended, and the alternative treatment with better stabilized safety profile during breastfeeding are preferable, especially while nursing a newborn or preterm infant. Undesirable effect. Losartan has been evaluated in clinical studies as follows. In a controlled clinical trial in increased 3000 adult patients 18 years of age and older for essential hypertension. In a controlled clinical trial in 177 hypertensive pediatric patients 6 to 16 years of age. In a controlled clinical trial in increased 9000 hypertensive patients 55 to 80 years of age with left ventricular hypertrophy. See leaf study pharmacodynamics. In these clinical trials, the most common adverse event was dizziness. The frequency of adverse reaction list below is defined using following conversation. Overdose. Symptoms of intoxication. Limited data are available with regard to overdose in humans. The most likely manifestation of overdose would be hypertension and tachycardia. Bradycardia could occur from parasympathetic stimulation. Treatment of intoxication. Its symptomatic hypertension should occur. Supportive treatment should be instituted. Measures are depending on the time of medicine product intake and kind and severity of symptoms. Stabilization of cardiovascular system should be given priority. After oral intake, The administration of a sufficient dose of activated charcoal is indicated. Afterwards, close monitoring of the vital parameters should be performed. Vital parameters should be corrected if necessary. Neither losartan nor the activate metabolite can be removed by hemodialysis. Incompatibility, not applicable. Storage, store below 30 Celsius, protect from light. Presentation, SART 25 blister of 10 tablet, SART 50 blister of 10 tablet.